So moving to our next session, which is of lungs attack, what to do by Dr. Rajadhar sir. And unfortunately, Dr. Rajadhar sir is not here because of some personal issues and flight problems also. So he has given us a video message. So we are going to play his message, okay? And session also. So before that, I would like to call Dr. Utsav Samaria sir for as a chairperson, and Dr. Mohit Bhatia sir, and Dr. S.K. Pathak sir to please have a chair.
Hello. Dr. Rajadhar is one of my best friend. He's a best teacher. He's not available here, but he regarded the best or knowledgeable lectures here. We have to display this on the screen. This is the one of the important. कहा गया इस conference की पूरी जान है. The topic is lung attacks. What to do? There are many things, just I told you, that many things included in lung attacks. This is the lung attack is the umbrella where many diseases of acute respiratory failure conditions occurs. Here, this topic just started here with nice presentation. We have to listen carefully for our practice. The lung attack terminology we have to use in Varanasi first time. To aware the public, this is the not medical terminology, but as we know that heart attack, every patient know, every layman knows what is the heart attack. Here the lung attack topic is very important. We have to aware the public, we have to aware our patients about the lung attack, why it is important, then heart attacks. Thank you so much.
To all the chest physicians, I don't think Dr. Rajadhar needs an introduction. He's currently a GB member of the Indian Chest Society and a very senior consultant, and is a legend in his own right. He's also currently the director of Pulmonology in CK Birla Hospital and chairperson of training and education initiatives of Indian Chest Society. So I would now have Dr. Rajadhar begin his presentation. Lung attack, basically we know heart attack as Dr. Pathak said. Everybody knows heart attack by it's an MI situation. Lung attack is basically a awareness campaign which chest physicians want people to know that acute exacerbation of COPD is nothing but a lung attack, and it has to be dealt the same way. The seriousness is that a lot of patients die out of COPD even when we completely know the treatment. That's where the focus is going to be today. Thank you.
Good evening everyone. I just want to add one line. I will not take much time. Why lung attack is much important? Because every exacerbation, either due to the COPD or due to the other obstructive airway disease, it can increase up to the 25% risk of mortality in the next 1 year. So if the person having a lung attack or any exacerbation, that's the scientific terminology, so this person is going to be die, 25% of that patient is going to die in the next 1 year. Apart from this, there is a significant decrease in the lung function with every exacerbation, after every exacerbation of obstructive airway disease. It is an estimate around 10 to 15% fall in the FEV1 with every exacerbation. So without not taking much time, directly I refer to the Rajadhar sir for his lucid lecture. Thank you.
My name is Dr. Rajadhar and I'm a pulmonologist working in Kolkata. I need to start off by thanking Dr. S.K. Pathak for this kind invitation to speak to you on the 8th Respiratory Conclave Conference 2022 that's held under the aegis of the Breathe Easy Chest Foundation and Humanity associated with IAVA. It's a privilege to talk to you. I'm very sorry I could not come and see you in person due to extraneous circumstances. However, I will try my very best to talk on this topic, which is a challenging yet interesting one for me. Lung attacks, what does one need to do? Now you would understand that this is not a nomenclature that has come into official use. However, it's something that we need to think, and going forward, a terminology which we feel would help people in understanding lung diseases and exacerbations better. So I'll start off by introducing the concept of a lung attack. I will tell you about COPD first, because that would be the archetype where you might end up getting a lung attack, and I will do it with introducing the concept of inflammation and comorbid IO. I will tell you what entails lung attacks, the fact it's not just about acute exacerbation of COPD, but also about acute severe asthma, about acute exacerbations of interstitial lung disease, and I will briefly cover the management of these conditions. I'll then finish off by talking about two other topics: what else might come under the umbrella of a lung attack, and why this terminology. Is it just a terminology for the sake of introducing one, or is there some logic, is there some rationale in using this terminology? So we start off with COPD. I said that's the archetype, that's where you can get a lung attack. And COPD, as you all know, is a heterogeneous disease which has pulmonary and important extrapulmonary components, and these often don't go hand in hand. You might have more of extrapulmonary, or you might have more of pulmonary defects. How much of pulmonary disease or extrapulmonary disease you have might not always be reflected by the FEV1. I show you this cartoon which tries to introduce the concept of inflammation. So you have a trigger, air pollution, smoking, biomass might be the triggers. Inhaling these triggers results in setting off the inflammatory cascade in the lung. This inflammation can spill over, and I'll talk about this more in a bit, but this can spill over to other organs, and you can see the muscles, the pancreas, the heart, the liver, etc. being depicted, and the effect on them being depicted. How do you know that the inflammatory cascade has been triggered? Markers like raised white cell count, raised CRP, IL-6, and fibrinogen might be markers of inflammation and exacerbation in COPD. They have also been looked at as being markers of mortality. We know that mortality in COPD is not just related to the severity of lung disease, but also by the symptoms of other systems, especially the heart, hence extrapulmonary complications. We started off talking about lung attacks. Why am I talking about comorbidities? This is to establish that, like you have attacks in other organs, the heart, the brain, for instance, you could have a similar inflammatory cascade in the lung, not limited to the lung, but spills over to other organs, and hence the manifestations of the lung or the lung attack might not be very different to what happens in the heart or in the brain. This is the lovely study from about 3 years ago, which looks at data from prevalence of comorbidities in COPD. The most important comorbidity by far is cardiovascular disease. So heart attacks, as you see on there, is a very important factor causing mortality in patients with COPD. You can see the various cardiovascular manifestations, and then in yellow, the yellow bars show you the non-cardiovascular manifestations. I won't read through this for you, but you can see ischemic heart disease is a comorbidity which is there up to 25 to 30%. That's a large number. No wonder that lung attacks and heart attacks might happen with the same set of risk factors. This shows you the association between cardiovascular disease and COPD in slightly greater detail. Again, I don't need to read through all the hazard ratios. However, it suffices to say that the risk of all of the cardiac complications that you see on that slide is increased if there is coexistent COPD. The hazard ratio can be anywhere between 1.4 to 2. That's a significant rise. But again, you see that lung attacks and heart attacks can go hand in hand. The same risk factors for systemic inflammation and a lung inflammation, and hence these attacks can go hand in hand. And this is a very large study which comes from Netherlands, and it looks at the population of comorbidities in patients with COPD, about 14,000 odd patients with COPD, and you can see cardiovascular comorbidities is far greater in the COPD population as opposed to in the non-COPD population. Comorbidities associated with development of first exacerbation. So the risk of getting an exacerbation if you have a comorbidity like heart failure, for instance, is far greater. And comorbidities associated with more than 2 exacerbations per year is always greater as compared to those who have less than 2 exacerbations per year. So increased spurt of inflammation, a spike of inflammation, can result in greater cardiovascular comorbidity. This is a lovely slide from the European Respiratory Journal 2018, which looks at this correlation in greater detail. The fact that the manifestations of one can feed into the other. Hence, COPD leads to exacerbations, to hyperinflation of the lung, hypoxia, systemic inflammation, we have said before, arterial stiffness, exercise intolerance, and deconditioning of muscles. And all of these factors tied together can result in increased cardiovascular risk or increased cardiovascular disease. You've seen a similar slide a little while ago, so I won't labor the same point again. However, suffice to say that increased inflammation in the lung, reflected by increased IL-6, CRP, TNF-alpha, and tissue hypoxia, results in oxidative stress. A lot of inflammation spills over to the bloodstream, and this results in the manifestation of other organs, which we have spoken about a little while ago, especially the heart. And in these people, there's lack of nutritional supplementation, and this results in the muscle wasting that you see in patients with COPD. So thinking about all this, 2011, there was this edition of Thorax, which talked about lung attacks. The other people who've spoken about this before, but the credit of this official nomenclature should go to Mark Fitzgerald. And I'll read a small section from this particular article, and I'll read more at the end because it puts into perspective why Dr. Pathak has asked me to speak about this topic today. So it says, in the case of COPD, the outcomes are even more dramatic. So when he says about COPD, it's about COPD exacerbations he talks about. In-hospital mortality per acute exacerbation of COPD is about 10%. And 1-year mortality post-hospitalization approaches 25%. He also says that in addition to these immediate increased risk factors in exacerbation, there's a significant decline in lung function, and hence this adds to the risk of future exacerbations. The response of the healthcare system to these events, what he has termed as lung attacks, is disappointing, he says. The response, he says, is very different to heart attacks. You guys think of it. Heart attack alarms people. It makes people sit up and take notice. It means you need to go to the hospital immediately. It would trigger a whole cascade of events which happen when people talk about a heart attack. We've understood pre-COVID and even more post-COVID that a lung attack, the way we have termed it today, is no less significant, no less risky or dangerous. Why would we not speak of lung attacks and put it at par with a heart attack so that in the patient's mind they fathom the seriousness of this condition? He's also said about bundling medications together at discharge. He's talked about rehabilitation, but I'll come back to these points at the end of my talk. So an exacerbation of COPD, and this is a dated definition which has not changed. Gold in 2016 said that an exacerbation of COPD is an acute event characterized by the patient's worsening respiratory symptoms beyond normal day-to-day variation, and this leads to a change in medication. This is from the Eclipse study and the New England Journal from about 10 years ago, and this looks at distribution of exacerbations according to the Eclipse study. And you can see according to gold staging, moderate, severe, and very severe disease, the number of exacerbations in the past year matters. If you got one exacerbation per year in the last 1 year versus 2 exacerbations in the past 1 year versus hospitalization for exacerbation in the last 1 year, the implications are very, very different. And I want you to remember this distribution. Lung attacks, risk factors need to be identified, and hence the morbidity and mortality can be defined based on prior exacerbations. What about FEV1 decline over the last 4 years and exacerbation frequency? And you can see again on this paper from lots of years, 20 years ago now, the fact that frequent exacerbators are far more prone to having increased exacerbations, recurrent exacerbations, as compared to infrequent exacerbators. Why is this important? This is important because every exacerbation results in a mean of 25% decline in FEV1. That's a large number, 25% decline in lung function. We've spoken about triggers. I won't waste your time harping on this point even more, but suffice to say that along with the pollutants, the smoking, the biomass I spoke about, infections, both bacterial and viral, are important. The inflamed COPD airway results in systemic inflammation on one hand and bronchoconstriction, edema, and mucus formation on the other, and this results in the exacerbation symptoms and the dynamic hyperinflation we speak about in patients with COPD. The fact that the survival curves relate to prior hospitalization history. I spoke about this a little while ago. This is just a graph to show you the same. In people who had no hospitalization, the survival is far better, far greater, and you can see that on my cursor hopefully, far better survival in never exacerbators as compared to people who had a COPD hospitalization in the past 1 year. Oxygen and ventilator support, especially non-invasive ventilator support as appropriate, and then discharge and follow-up is what needs to be done. Very quickly, this is looking at the various exacerbation types according to Anderson's criteria, and the fact that irrespective of type of exacerbation, antimicrobial therapy seems to be better as compared to the placebo group in this trial. So successful treatment was 68% in the category of patients who got antibiotics versus 55% in those who did not. Oral steroids improve mortality, they reduce the duration of hospitalization, and sometimes they can prevent hospitalization, as was shown up in this seminal paper from the Lancet from 22 years ago. So corticosteroid treatment, much better bronchodilation, much better FEV1 as compared to the category of patients who did not get corticosteroids. And this is a JAMA paper from about 10 years ago, which looks at duration of steroid use. This is the reduced trial, and it shows that short-term steroid use seems to work better as compared to the weaning doses of steroids over a 15-day period. However, this needs to be individualized, but overall, a short duration of steroids is at least no worse as compared to a longer duration of steroids. We spoke about lung attacks. And the important thing about lung attacks is bundling care. You bundle care into groups like you would do in cardiac rehab, for instance, when a patient with a heart attack goes home. And this bundle would include things like education, optimization of medication, the review of inhaler technique, assessment and management of comorbidities, starting early pulmonary rehabilitation, maintaining contact with your patients even if it's remotely in the way of telemonitoring. So that forms a bundle. And therein lies the importance of bundling care and calling these lung attacks. But I'll come back to this again in a moment. We spoke about telehealth. This is a telehealth study from a long time ago. This is pre-COVID times. And now with COVID, this is much more a possibility. And this shows that telemonitoring entails better control with less exacerbations as compared to people who have physically come to a clinic and do not manage to do so. So telemonitoring is much better as compared to no monitoring, and sometimes even as good as physical attendance in clinic. So that is Scott's study, and I want you to remember this. Remember, you can remotely monitor your patients and follow up at least once in 3 months to make sure that the disease is under control. So that lists the strategies to prevent exacerbations, the pharmacological and non-pharmacological treatment. I won't read through this slide because it's not the ambit of my talk. That'll give you 10 seconds to look through that list. That's the list you need to remember, because this list prevents exacerbations, and we talked about the amount of damage and exacerbation can do to your patient with COPD. This looks at managing stable COPD and pharmacological treatment. Again, I put this slide up just to emphasize that patients need to comply with this therapy so that they don't exacerbate and the patient's disease does not progress. So the stable state, the green is important, the red is bad for you, exacerbations are bad for you. You need to identify patients who have a high exacerbation susceptibility. The fact that persistent inflammation and slow recovery due to secondary bacterial infections are important, and they need to be prevented or treated depending on the clinical scenario. So that was me talking about COPD. I'll now briefly touch upon asthma for the next couple of minutes. So from a goal-centered treatment in COPD, I now go to a GINA-centered treatment in asthma. And again, all of you know the definition of asthma, but just for the sake of reiteration, it's a flare-up or exacerbation causing an acute or subacute exacerbation worsening of patient's symptoms and lung function compared to the patient's usual status. So see the similarity between the definition of COPD exacerbation and asthma exacerbation. So in an exacerbation, when your patient is acutely breathless, with an exacerbation of airways disease, you can club these together. You can create care bundles and discharge, which take both of these into account, and hence you can call both as lung attacks. Flare-up is preferred term for discussion with patients. They understand that better. Exacerbation is a difficult concept, and that brings you to an important point. Use words which your patient understands. Don't use jargon. And lung attack is a terminology that your patient would learn and understand well. Attack has variable meaning for patients and clinicians, and episode does not convey clinical urgency. Consider the management of worsening asthma as something you need to think about when your patient is stable, and hence a written action plan, a self-management plan becomes important. Management in primary care becomes important, and follow-up after the exacerbation becomes important. How do you identify patients who are at risk of asthma-related deaths? Any history of near-fatal asthma requiring intubation or ventilation in the past is a risk factor. Hospitalization and emergency care in the last 12 months is important. Not using an ICS, we now know, with 2019 GINA guidance and beyond, is a huge risk factor for asthma exacerbations. Overuse of SAVA is important, lack of an action plan is important. It's a long list, but you guys need to remember this list, because otherwise you end up with a lung attack in your patient with asthma. And patients who don't do these, flag these up during review so that you know these are the at-risk patients for a lung attack. What's the rationale for change in recommendation about controller therapy? We have said that for the last 10 years, the guideline recommendations have remained the same. However, we now understand that ICS is vitally important irrespective of how early or how mild asthma is. And hence, with the Sigma trial, the guidelines have changed. Patients have been told to start ICS in GINA 1 in the mildest of asthma. In fact, in asthma today, it's important not to miss out on a puff inhaled corticosteroid with any puff of inhaler that you take, irrespective of the stage and severity of asthma. Adherence to inhalers generally in patients is poor, especially so in asthma where patients perceive themselves as being normal. Patients would only take 25 to 35% of the prescribed controller dose, and hence taking the inhaled corticosteroid becomes important. This is the GINA algorithm for managing exacerbations in primary care. And again, I won't read through this because this is easily available online on the GINA website. But important to say that you need to identify the patient who's exacerbated or had the lung attack. You need to divide them into mild, moderate, and severe because that decides whether you manage to treat them at home or you manage to treat them in hospital. You need to identify the one with life-threatening attack because they need to get into the emergency for hospital and then into the intensive care as early as possible. And you need to start the steroid, the short-acting bronchodilator nebulized, at least through a spacer, giving the SAMA or the SAMA as early as possible. And you need to assess response again within an hour. So the steroid, the short-acting bronchodilators need to get in as early as possible. And then you need to make discharge plans and make sure that you activate the care bundle for the lung attack that we spoke about a little while ago. This looks at severe attacks, the fact that life-threatening attacks are identified in patients of asthma becoming drowsy, which indicates hypercarbia, and a chest which is silent as opposed to being wheezy. So silent is worse than wheezy. Remember that for the youngsters out there. That's a clinical nugget that you need to remember being a physician or a respiratory physician throughout your life. Important to administer the steroid and the short-acting beta agonist and the SAMA while the patient is getting transferred to hospital in an ambulance. We spoke about the initial management already. So what it shows here, two important things. You give the patient the appropriate treatment, but keep reassessing the patient. Make sure that your patient is responding to therapy. And then you assess them for discharge, you have a discharge plan, and again I keep repeating myself, make sure that the care bundle we spoke about remains. The controller inhaler or the maintenance inhaler, the reliever inhaler are now one inhaler. That's the SMART therapy. We said ICS to every puff of inhaler that your asthmatic patients have taken. Make sure that you identify risk factors at the time of discharge, and the home action plan, if it was not written before, needs to be written again. The previous one was in primary care. This is in acute care settings. These are sicker patients, but the management does not change hugely. Maybe in these patients doing a peak flow, especially in young patients, is useful. However, it's not as important as giving the short-acting bronchodilators and the inhaled corticosteroids early. So I'll give those a miss for the lack of time, but suffice to say that the management remains more or less the same across classes of asthma, whether you treat them in primary care, secondary care, or tertiary care. A couple of words about interstitial lung disease. So AEILD would come under the ambit of a lung attack also. What are the diagnostic criteria for an acute exacerbation of IPF? And I would argue this is the same for any ILD. So these are patients who have a previous diagnosis of ILD or IPF. You have unexplained dyspnea with worsening of symptoms. If you have a previous CT which shows honeycombing and traction bronchiectasis, you know for a fact that you're dealing with someone with ILD or maybe even surer with IPF. And you need to exclude other causes of breathlessness like left heart failure, pulmonary embolism, ARDS, etc. Important words that you need to remember when you see your patient with ILD. And then the management of IPF patients. Antifibrotic drugs and lifestyle modifications are more for prevention of exacerbation. The therapeutic approach is high-dose systemic steroids, immunosuppressive therapy in some cases, and broad-spectrum antibiotics because infections are difficult to exclude in these patients. Remember that all of these guidelines in AEILD are non-evidence-based. They are mainly based on expert opinion. Lots of publications on the incidence of AIPF, but important to say that they happen. And when they happen, they can kill your patient with interstitial lung disease, and hence it's important to recognize them early. Again, the concept of care bundles come in. This management is not hugely different to what you would get in your patients with airways disease. It's not just about ILDs, no other conditions. We talked about the heart and the lung together. Often when patients exacerbate with COPD, they also develop diastolic or systolic heart failure. Heart failures are important to recognize. There are specific tests for these. Your patients with COPD, the ones with severe disease, are virtually immobile. They might be tied to a bed, and hence these patients are at risk of pulmonary embolism. There's risk of a pneumothorax in patients with cystic lung disease, as happens in your patient with emphysema, and I have said that lung infections come as a part and parcel of COPD. So these are your differentials. They would also be under the broad umbrella of a lung attack. Their symptoms might not be hugely different, and most important, remember that there might be an overlap between the diseases that we've spoken about. Hence, a patient with COPD can come in with a pulmonary embolus, they can come in with a lung infection. Your patient with asthma might come in with a pneumothorax. Hence, making one diagnosis does not mean that you don't exclude others. Overlaps are important, and hence it's important to remember this approach, which is in front of you on the slide just now. Take a coherent history, do a proper physical examination, do your blood markers, your CRP, in some cases your procalcitonin is important. Imaging is important. A chest X-ray, but more importantly, an HRCT tells you what the diagnosis is in a lot of cases. Do an echocardiography to see whether your patient is in heart failure or not. In some cases, when you try to exclude infection and you're going to pulse your patients for acute exacerbation of ILD, you might need to do a PAL. However, the risk of hypoxia, denuded or PAL must be kept in mind, and you need to select your patients for a bronchoscopy and a lavage wisely in this category of patients. But very important, try and identify the etiology of a lung attack, and remember to manage overlaps, like I said just a little while ago. So that's my concluding slide. The terminology of lung attacks is important. So Dr. Pathak understands that a lung attack is important because one leg of care which is very much seen in patients with cardiac disease, even in nosocomial infections, is something that needs to happen in exacerbations of lung and airways disease. These diseases are associated with mortality, almost as much so as happens in patients with heart disease. If this terminology of lung attack was used in the emergency department, at the time of discharge when your patient recovers, as they will do in most cases, there needs to be a standardized list format in the discharge particular of these patients needs to be looked at. We need to be focused on exacerbations of asthma and COPD, but we should not forget the other conditions that we spoke about, including the interstitial lung disease, which is being diagnosed with increasing regularity. And then again, I read from Dr. Fitzgerald's paper, which says that the recognition of asthma and COPD as major chronic diseases in emerging economies, the potential to perform large trials in these settings in a cost-effective and timely fashion will also be convenient in countries like India and China. These studies need to be pragmatic, but they will be appropriate as these countries will probably be the location of an emerging epidemic of respiratory as well as other chronic diseases. These are wise words. It's as if he had a crystal ball to look at and he could look 10 years down the line, which is now when chronic lung diseases are rampant, and it's rampant especially in countries like India and China. I hope you enjoyed that talk. My sincere apologies again for not being able to be there in person, and I wish you all the very best for the rest of the meeting. Thank you so much for listening in.
So I think that was the most apt description of lung attack. And lung attack, as per Sir, as Sir has explained, is not just limited to COPD. It's severe asthma, an exacerbation of asthma, exacerbation of ILD, and pneumothorax, any lung infection. All of this can be bundled into one care. And just that, when a patient comes to you when he's serious, it's not just in an ECG and RBS, you should go ahead with an X-ray also. And seeing the paucity of time, I would like to hand over the session to Swapnil, my little brother, and have 2 words from Dr. Mohit too.
It has been concluded about the lung attack. So how the time changes. When we were students, so my teachers are sitting here, in the most of the guideline and book, it was written, it was in writing that we should not use the term like lung attack and this, because it may cause panic and they are misleading. But now the paradigm has been changed. There is a shift in the approach towards the patient. So they approach more toward the bundle of care. So we have to make a public awareness about these lung conditions. The basic idea about the changing this terminology to the lung attack is to make more awareness in the public and the general physician who are treating at the grassroots levels. They can early refer the patient to a appropriate center so that these patients can diagnose properly and can manage successfully with the positive outcome. Thank you.
Now to honor chairperson of this session, I would like to call Dr. Swapnil.